All right, we are finally moving into the fourth unit where we will start talking about actual diseases. Now, we are going to go through the kind of systems where we see a lot of diseases. So, we are starting with the skin and the eyes for this particular unit. I do want to take a quick moment and say, thank you for listening to these lecture videos. However, if the only way that you are studying is by listening to these videos, that is fine, but probably won't be helpful in memorizing the material. So up till now, if all you've been doing is listening, that's great. That's a good way to refresh the information in your mind. However, other ways to apply this information is to make flashcards or quizzes to apply the knowledge itself. Or rewrite your notes over and over. You could do that with these lectures if you feel so inclined. But that is a way to make sure that the information is sticking in your head. So kind of keep that in mind as we go through these diseases, because there is quite a bit. And just listening to the diseases and the microbe type, the causative agent, all that's not going to help you remember it. You need to put it somewhere in writing so that you can test yourself and see if you actually remember that information. Now, if you have not found it already, in our Brightspace, I have put a template on essentially a study guide template. So that you have an easier way to kind of keep all of this information together in one spot. Now, your notes and note packet are fantastic, but that would be another way that you could apply this information and put it into that study guide. You'd have to rewrite it. You have it all together. You can reread it over and over. I think that would be a very useful tool in helping you remember these diseases and all of the important features that I want you to remember of the diseases themselves. So let's go ahead and get started on the diseases for skin and eyes. So the first thing we need to discuss is the importance of the skin and how it is able to get the various diseases from those different microbes. And that is because your skin is that boundary, or you can think of it like a shield, between you and your environment. And it is constantly interacting with microbes all the time. We are covered in microbes on the outside of our skin, and of course, the environment itself is full of microbes as well. Now, your skin, as a gentle reminder from your anatomy and physiology days, includes your skin, hair, nails, and sweat and oil glands. All of those accessory structures with your skin can be portals of entry for microbes as well. So not just a cut, but those various structures can be portals of entry and can become infected. Your skin is the largest organ on your body, and thus when it becomes infected, it can be kind of a bigger issue depending on which disease we're talking about. Your skin has many lines of defense to protect you. The first one being the process by which it grows. Now, if you, again, remember back to A&P, you will remember that the top layer, the epidermis, is going to grow from that bottommost layer, the stratum basale, up. So it's kind of like a push pop. It pushes up from the bottom so that those top layers fall off, or we call it sloughing off. And what this does is it sheds the microbes on the surface of your skin essentially daily so that you don't get this overwhelming amount of bacteria or other things like fungi living on your skin constantly. So you're kind of pushing them off along with that top layer of skin all the time. We also have these defensins. These are going to be not dissimilar to what we talked about before, I think in the last chapter, in the last unit. So these are kind of like little proteins that will essentially pop holes into the bacterial membranes. This is another important defense of the skin to manage how many microbes are living on your skin. Another defense is going to be the sebum from your oil glands, or also kind of like that oily sweat, if you want to think of it that way. So usually this is released somewhere close to your hair. And we often think of having oily hair as being a negative. However, it is one of our defenses against microbes, as well as it's important for our hair to be healthy. Kind of acts as a protective seal and a lubricant, very important. So this oily secretion, this sebum, is going to have a large amount of lipids, so fats. And the sebum itself is going to kind of act in two parts to protect us. One, it's going to act like a sticky trap to trap microbes in it. And then as the microbes are trapped, they're going to take advantage of the fact that there's lipids within this secretion and consume those lipids. Now, as the lipids are consumed for that bacterial metabolism, they start to create a toxic byproduct that ends up inhibiting the growth of microbes and also kind of poisoning them. So that's kind of a neat defense. And it's also kind of an important little PSA to not wash your hair every day with shampoo because you do want those natural oils in your hair, on your body too, to protect yourself against microbes. It's important for your hair, important for your skin. You don't want to dry out. That oil, that natural oil, is very important. Now, just regular sweat, not the oily sweat, is also very important because it has a very low pH. Not as low as, say, like our stomach acid, but it is a lower pH and a very high salt concentration. This creates a very hostile environment on the surface of our skin for most microbes. They don't want to be in that type of environment. And then last but not least, we do have our lysosomes, which are found in our sweat, tears, and saliva. And what lysosomes are is essentially buckets of little acid that can break down the peptidoglycan in the cell walls of bacteria. So this is another really neat line of defense when it comes to our skin. Now you might be thinking at this point, well, there's so many things. There can't be that much bacteria growing on our skin. There really is, though. There's quite a bit. So we have our normal microbiota listed out here. And I do kind of just want you to know those 4 groupings and maybe not necessarily those specific species. However, we will talk about quite a few of these with the various diseases because they do come up pretty frequently. Now that leads us to kind of the most common thing that we will see when it comes to skin diseases, and that is rashes. And rashes can be described using 2 descriptions, the first one being their location. So we have this term exanthem and inanthem. Exanthem is going to be external rashes, like a skin rash, And then enanthem is going to be an internal rash. You might be thinking, how the heck do we even know we have an internal rash? This is usually somewhere where we have a mucous membrane rash, such as inside of your mouth, which we're going to look at measles starting off. And with measles, we have something called Koplik spots. That is a white rash that forms on the inside of the cheek. So that would be a good example of an enanthem rash. The other identifying feature of defining a rash is going to be the type of lesion that is caused. So we have a vesicle, a bulla, a macule, and a papule. The first two, a vesicle and a bulla, are both fluid filled. It just depends on the size. For vesicles, these are small fluid filled lesions. A good example would be chickenpox, which we will talk about later in this lecture. And then a bulla is going to be particularly bigger. Usually we call these maybe boils. So we can see in that picture the difference in size of those lesions. For macule and papule, these are usually going to be lesions that lack fluid. However, papules kind of have a separate little side thing. In a macule, this is a flat laying lesion that does not have fluid. An example being scarlet fever, which is what we see directly to the right there. And then in papules, like in measles, this is usually a raised and solid lesion. However, they can contain pus or essentially like a thicker fluid. However, I'm kind of reluctant to call it a fluid because it's usually chunky. There's usually some type of substance to it. If you think of like the contents of a really thick pimple, sounds kind of gross, I'm sorry, but it's kind of like cottage cheese, this pus. And usually if a papule contains pus, we call it a pustule. So let's look at them kind of a little more closely, these 4 types of lesions. So we do have our vesicle and bulla at the top. Again, the difference between them is their size, and they are fluid filled. So if on the exam I were to talk about these structures, I would use the word fluid. For macule, that is a flat lesion, does not contain any fluid, and then our pustule or papule, depending on if it contains pus, is going to be in that bottom corner. And again, I will use the term pus, not fluid, because that pus is going to be thicker and potentially chunky. So a little bit more on the solid side. Starting us off with our skin diseases, we will be looking at maculopapular diseases. So these are skin conditions that are defined by having a rash that is a usually flat to slightly raised rash. So there are 5 main diseases in this category of maculopapular diseases: measles, rubella, fifth disease, roseola, scarlet fever. So we will look at all of these individually. However, before we jump in, you're going to see on the slides different features of each disease kind of laid out very clearly in bold. And that is going to be the type of disease, or more so the type of microbe that causes the disease, the cause or causative agent, the reservoir, the transmission of the disease, signs and symptoms of the disease, and then finally the treatment and prevention. When it comes to what I need you to know for the exam, I need you to know the microbe type, the causative agent, the reservoir, transmission, and then the unique signs and symptoms. I do not need you to remember the treatment and prevention. That will be something that you learn through your careers potentially. But I do want to go over them just because I think it's important to talk about it, but you don't have to memorize it for the exam. So those 5 things, and like I said before, there is a study guide template if you wanted to use that. I think that would be really smart, really helpful. All right, kicking it off with measles. Measles is going to be the microbe type virus. The causative agent, and the only thing I want you to know, is that genus Morbillivirus. And then the reservoir, if it is not actively making you in that moment sick, is other humans. So humans are the reservoir. That is where it exists if it's not actively making you right now sick. The transmission is going to be respiratory droplets. And this is one of the biggest reasons that, one of the 2 biggest reasons that measles is so highly contagious. You can just be talking or breathing and pass measles on, let alone coughing or sneezing. When it comes to how contagious it is, the other part of that is that, remember, measles has a long incubation period. So in that incubation phase, you are contagious. So if you're talking to somebody or kissing somebody or breathing on somebody, whatever, you are still contagious even though you don't know you're sick. So remember, in incubation periods, you aren't showing any signs or symptoms, but again, you are contagious, and this is a highly contagious virus. Now, there are a handful of signs and symptoms here. I don't want you to know all of the kind of common signs and symptoms because that kind of fits just about anything, like a sore throat or a cough or a headache. I want you to know the really unique symptoms, such as these Koplik spots inside the cheek. So we do have that exanthem rash, which is going to be these red maculopapular rashes starting on the head and usually moving to the trunk of the body and sometimes to the extremities. However, the Koplik spots on the inside of the mouth, usually inside of the cheek, maybe the back of the tongue, and maybe the roof of the mouth, are a very defining feature of measles. So that is a very important symptom that I would like for you to write down and know. Now, the rash itself is not the concern with measles. It's all of the complications that come with measles that makes it so deadly and so scary. So there are possibilities for secondary infections when it comes to measles, because the vast majority of individuals that we see contract measles is usually kids, and they don't have that great of an immune system because they haven't had the time to build it up. The other concern is encephalitis and subacute sclerosing panencephalitis. This is brain swelling and then brain inflammation. These are the 2 really scary side effects or complications of measles itself. It is normally fatal, and if it's not fatal, there is lasting damage, brain damage, that will not heal. So that is the concern. And it's not always directly after you contract measles that these complications arise. It could be 10 or 20 years later that this happens after you've contracted measles, but it is still the measles virus that causes the swelling and inflammation of the brain. So how do we stop measles? Well, the only thing we can do is preventative care because there is no treatment. So it is a virus. We don't really have that many antivirals. So we have to prevent individuals from getting measles. The vaccine itself helps prevent individuals from contracting measles. But if you do get measles and you've had the vaccine, it is a very, very, very low chance that you will have those complications that would lead to brain swelling and brain inflammation. So that vaccine itself is the MMR vaccine, which is a very, very important vaccine. So the MMR stands for measles, mumps, and rubella. And then we'll talk about, if you've heard of the MMRV, we'll talk about that one a little bit later when we talk about chickenpox. So one of the things that makes this vaccine a little bit famous is that it was used in a study. I say that a little bit facetiously, back in the 90s, that linked vaccines to autism. There is no link between vaccines and autism. However, there are potentially other concerns when it comes to vaccines. That is not one of them. Now, what that article did, and mind you, it was retracted very quickly because no one could repeat the data that researcher got. That article is still quoted today, and that was almost 30, 40 years ago, and there was nothing to it. It didn't actually show anything of substance. So the concern now is that measles and mumps, rubella, chickenpox, as well as other preventative viruses that have vaccines are starting to come back up due to this fear of vaccines causing autism. So in the early 2000s, we did see that measles was declared eliminated. However, entering into the early to late mid 2000s, and then up until more early times, we are seeing this gradual increase of measles reemerging, and that is due to that fear of vaccines because of that article. So we are seeing that upward trend going back up, which is really not good. It again has everything to do with a fear of the MMR vaccine. Now, this is kind of a neat chart showing the number of measles cases reported by year. Between 2018 and 2019, we're seeing quite a few cases, but then in 2020, it drops down to a very low 13, and that's because nobody was going out or around each other. So we can kind of really see how that COVID pandemic affected a lot of other disease cases. Because people were not interacting with each other, those diseases were not being spread. Kind of interesting thing to see, that little relationship there. Now, this is a little out of date, but if you decided to look up this information yourself to see what the current, as of right now when I am doing this lecture, in the spring of 2025, we are currently in the midst of a measles outbreak. And what we are seeing is roughly 400 cases as of the moment. And I'm sure in future semesters, if you are listening to this, that number will probably increase, as it is a highly contagious disease. And again, it has that long incubation period where you don't know you're sick, but you are still spreading the disease. On top of that fear of vaccines, so people are not getting their kids vaccinated, or they themselves are not vaccinated. And so we are going to see more cases of measles in the upcoming months, potentially years. Moving on to rubella, sometimes called German measles or the rubyvirus. The microbe type is a virus, and in the causative agent, kind of going hand in hand, is the rubyvirus. The reservoir, if it's not actively making you sick, is humans. We only get it from other humans. The transmission is respiratory droplets, and it can also be transplacental, meaning it can pass from mother to fetus. This is a very important transmission to make a note of, because this is where rubella becomes very concerning. So I'd maybe put a star or highlight next to that transplacental transmission. That is the one that we are really worried about. And then as a little side note, you can also get rubella from urine. This is pretty rare, so unless you are essentially kind of bathing or swimming in urine from another human, don't know what you do in your free time, but hey, no judgment here. You can get rubella through that type of transmission. So this is where rubella gets a little bit scary, is the type of transmission is going to lead to certain signs and symptoms that are particularly concerning. So we have postnatal rubella, which means that you've contracted rubella after you were born. This is the one we don't really care about. I mean, we care about it, don't get me wrong, but there are no real concerns as far as the signs and symptoms go. There's a rash, and that's kind of it. It resolves itself in a few days, and most often than not, adults don't even show any signs or symptoms. It's the other one that we're really worried about. So if the transmission is transplacental, meaning that a pregnant mother passes it to her unborn fetus, so a prenatal rubella transmission, what we can see is a teratogenic effect, meaning that it will harm the fetus. Even if mom's fine or her symptoms are really mild, the fetus will be harmed. Depending on when the infection happens, can kind of depend on how severe those signs and symptoms are, and often results in a miscarriage. And if it does not result in a miscarriage, it usually causes permanent birth defects that affect the nervous system within the fetus, so that after birth, the life expectancy is pretty low. Causes lesions on the brain, typically in more severe cases. And at that point, there's so many things kind of compounding on each other, more complications on complications that lead to even more complications, that the newborn or potentially infant, depending on how long they survive, will likely die within about a year, maybe two. So what can we do? There is that prevention, which includes the MMR vaccine. So again, that still includes measles. That does include this particular type of measles, this German measles, this rubella. However, again, because of that study, people are not taking this vaccine, and we are seeing rubella also on the rise with our regular measles too. Now, when it comes to the treatment, there really is no treatment because it is a virus. We don't have that many antivirals. And kind of the only thing that we can sort of do for newborns that have received the virus transplacentally, so prior to birth, but then they did survive, there was no miscarriage, and then they are born. Sometimes the only thing we can do is to try to make the infant comfortable until death. All right, moving on to fifth disease. This is shockingly the fifth disease discovered that caused rashes in kids, and this was roughly 100 years ago. So That is why it is named fifth disease. It does have another name. You can know it as that, but I would know it as fifth disease just because that's probably easier to remember. The microbe type is a virus, and the causative agent is something called a parvovirus. Now, this might ring a bell if you have dogs. This is not the same parvo that is found in dogs, though. Similar microbe, but different strain. So the reservoir is humans. So again, if you are not actively sick, other people probably have this disease and are housing it until maybe you get sick, hopefully not. The transmission type is respiratory droplets. You're going to notice a theme here. There's quite a few that are just respiratory droplets. The very unique sign and symptom here is going to be this slapped cheek appearance. Now I'm going to show you a picture here in a slide or two, and it really does look like these individuals have been kind of like pinched or slapped on their cheeks because they're quite red, or potentially you could describe it as looking flushed. There is no prevention, there is no treatment. However, this particular disease is very mild. So the biggest thing is that it shows this slapped cheek appearance. Now, you've probably seen kids look like this, running around the playground, and their cheeks get really red, they look really flushed, and this is potentially fifth disease. You might be thinking, well, they didn't seem sick. Well, with fifth disease, the interesting thing is that the virus wakes up and causes this symptom if the person who has contracted the disease gets hot. So it responds to temperature. So kids running around a playground, getting their body temperature increased, they end up showing this slapped cheeked appearance. So kind of interesting. Again, not a whole lot of other complications from fifth disease, just that they have this little slap-cheeked appearance, and usually we do see this in children. All right, on to roseola. This is also known as sixth disease. You're never going to guess why. Yes, it is the sixth rash disease that was discovered in kids. The microbe type is a virus. The causative agent is a type of human herpes virus. So HHV6 and HHV7 sometimes. This is different than genital herpes. Don't worry, that's coming up later in a few chapters. I believe it is the last one we talk about for the semester. Not herpes itself, but the last unit. The reservoir for roseola is humans. We only get it from humans. It is just living within our population. The transmission is respiratory droplets, and it can remain latent in human hosts for some period of time and reactivate at pretty much any point in time too. Now, it is defined as having a maculopapular rash sometimes, but for the most part, super weird. 70% of cases don't have a rash. The concerning sign and symptom is a very, very high fever that comes on really quickly and lasts for a few days. This is so concerning, guys, because in young children, a really high temperature really messes with their little developing brains, has to do with proteins, blah, blah, blah. Essentially, that high temperature causes them to seize. That is a super scary time for any parent, of course. So the transmission, and also talking about a little bit of epidemiology, it is thought that 100% of the U.S. population is infected with roseola by adulthood. So Most people probably don't show many symptoms of this, but, you know, it is what it is. Potentially we are all infected with roseola. The concern is when kiddos get it and those high fevers cause those seizures. There really is no vaccine for it. It's just kind of good hygiene is a preventative measure, and there is no treatment. It just kind of needs to run its course. So here we have the rash in some symptomatic cases. You can see that that rash is very subtle on the skin of these kids. Again, it's that flat rash, kind of mainly sticks towards the trunk and extremities a little bit, but mainly on the trunk. All right, we are finally moving away from viruses. Not that they're not going to come back up, they will. But our first disease that the microbe type is now officially a bacteria. We have scarlet fever. You've probably heard of scarlet fever. It kind of sounds like an older type of disease because it is. The causative agent is Streptococcus pyogenes. The particular way that this bacteria is going to cause an issue is through this exotoxin. So we've talked about exotoxins, endotoxins, and enzymes from the last chapter in discussing those different ways that microbes can cause damage to us. So this is going to be through an exotoxin. So it is an erythrogenic exotoxin that is going to cause inflammation and reddening of the skin because this exotoxin attacks red blood cells. So that is why we call it scarlet fever. The reservoir is us, humans. The transmission is respiratory droplets, but an interesting thing about the transmission is that it's usually stemming from the result of having strep throat, being infected with strep throat, and then this guy pops up. When it comes to signs and symptoms, yes, there is that rash. However, the very unique symptom that we can see is strawberry tongue, and I'll show you a picture here in just a second. And it is a not so great experience to have. So give me a second to explain that. The prevention is just good hygiene, and the treatment, because this is a bacteria now, is antibiotics. So kind of a new treatment that we can have. So to the left, we have a picture of that maculopapular rash. And then that bottommost picture of the tongue is the strawberry tongue. Has kind of the appearance of a very wet looking strawberry, I suppose. Not necessarily strawberry you'd maybe want to take a bite out of, but hey, there it is. So we do have this inflammation happening on the tongue that is so severe that it causes the top layers of the tongue to die, which is going to lead to that top picture of the tongue. So as those top layers are dying, they slough off, not dissimilar to the way the top layer of your skin sloughs off. So as it is sloughing off, it's kind of like a lizard shedding its skin, but it's your tongue shedding the top layers off. And then once that top layer has completely been removed, you go back to that bottom picture of that strawberry tongue, and it kind of keeps going back and forth until the antibiotics have run its course, until the microbe has left your system. So kind of an interesting symptom here, and maybe a little gross if you think about it for too long, sloughing off the layers of your tongue. All right, next up is impetigo. This is also another bacteria. microbe type, the causative agent is Staphylococcus aureus, where we see that particular agent with older kids and Streptococcus pyogenes in newborns. But more often than not, we do see a combination of the two. The reservoir is going to be humans, and the transmission is going to be a little bit different this time. Not just direct contact, but indirect contact through fomites as well as through mechanical vectors. So let's talk about that for just a quick second. So those indirect contacts, those fomites, if you remember from the last chapter, a fomite is a non-living surface that the microbe or virus or whatever we're talking about can survive on for some amount of time, and that transmission can happen if I touch the table and then you come in after me and then touch the table. We are not directly touching, that is indirect contact, and the table itself is the fomite. Now, the fomite in these situations for impetigo is usually maybe like play equipment, or a daycare, toys, maybe clothing or bedding, things like that. So, non-living surfaces. And then we have these mechanical vectors as well. And a mechanical vector is going to be a living thing, but the microbe is surviving on the outside of that living thing, that vector. And in this case, those vectors are usually pets, like maybe your dog. So you have this little kiddo comes up and is like, oh, I love your dog, and rubs all over your dog. Turns out they have impetigo, and that's on the surface of the skin. That bacteria and also that disease gets all over your dog, and then you go to pet your dog, and then you touch your face or something or whatever, and then now you have now contracted impetigo as well. Now, it is a mild disease. It's more uncomfortable, and it doesn't look great, but it is mild. It's not going to be a terrible thing. It can lead to other issues, which we will talk about, and it is highly contagious. Okay, so the signs and symptoms that we are looking for are kind of peeling, crusty, flaky scabs that are usually described as honey-colored crust. Ugh, which sounds really gross, and when you see a picture, you're going to be like, I know exactly what that is. You've seen it before, I guarantee it, if you've ever seen a young person, like a child or a toddler. And you may have thought that mom is not wiping that kid's face. That's gross. It's probably impetigo. So it's not a matter of mom not wiping the kid's face off, like, because they're all snotty and stuff. It is the fact that they have this condition. We'll talk about why. But children are the ones who primarily get impetigo on their faces. Sometimes you can get it on extremities, and that is where it becomes kind of an issue, especially if you contract impetigo on, say, like your elbow or your knee, areas that rub and stretch. This can be an issue because it opens up blood vessels. We'll see this on the next slide with the picture that I have. But the reason children are particularly good at contracting impetigo is for two reasons. One, their immune systems are trash. They don't have an immune system built yet to fight off these infections. Adults typically do. The second reason children are really good at contracting impetigo is because they touch everything, right? They're always into something. They're touching everything. And then what do they touch? Their face, their mouth, their nose. So, makes sense. Children are kind of the primary victims of impetigo. So the prevention is good hygiene. So washing your kids' hands, cleaning them off, cleaning various equipment. If you have a play date with your children, making sure everything's nice and sanitized. There are vaccines being worked on, however, they are not available. And then the treatment itself is going to be antibiotics because we are talking about a bacteria. Okay, so let's talk about the picture on the right first. So this is impetigo near the mouth and nose of a child. We've got those honey-colored crusts causing that scabbing as well. Now the picture on the left, that impetigo on the knee of a child, is the one that is the concern, because in those areas where skin is rubbing and can stretch and fold, that is going to be where the infection can kind of open up blood vessels and lead to secondary infections. That is the concern here. On the face, doesn't look good, but it's, again, more irritating, probably on the uncomfortable side, just looks bad. But it's not bad. It's not painful. The one on the left might be on the little painful side, but it leads to other things that will be a concern. All right, that leads us to cellulitis. So impetigo can lead to something like cellulitis. The microbe type is going to be a bacteria or potentially a fungus. We have our causative agents here, which should look familiar. They're very similar to impetigo, if not exactly the same, actually. The reservoir is us, and the transmission is an endogenous transmission. So I want you to think of that child's knee that had the impetigo. We have now opened up kind of deeper tissues, and that opens up an opportunity for cellulitis to get deeper into the dermis, or maybe the hypodermis if it's a particularly deep cut, or maybe that impetigo really opened up in an area like maybe the armpit or something like that. Who knows? But cellulitis can be a really bad thing because it is going to get deeper. All right, that is the thing here. So we want to prevent cellulitis by keeping wounds clean, using clean bandaging as well. And the treatment is potentially antibiotics. However, cellulitis may be caused by MRSA, which is antibiotic resistant, and that can be a really big concern. So that factor of transmission, that cellulitis is endogenous, is kind of what leads us to this next term, that cellulitis is a dermolytic disease, meaning that it infects deeper than the epidermis. So the epidermis is the most superficial layer of skin. The dermis is that middle layer, and the hypodermis is even deeper. So cellulitis is, by definition, going to infect those lower, deeper layers of the skin itself. So the signs and symptoms, this is going to be a lot of pain, tenderness, swelling, and warmth. But another really important and unique particular symptom is lymphangitis. So this is going to be red lines that lead away from the area infection. So you can see this on the skin, and it kind of looks like red spider webbing moving away from wherever the infection is underneath the skin. So this is caused from the microbes and inflammatory products being carried away from the site of infection through your lymphatic system, which is not a good thing. We don't want that. That's a bad thing, because the lymphatic system is going to inevitably dump into your bloodstream, And once in the bloodstream, this infection can now spread throughout the body and potentially lead to bacteremia. So you can get septic. Super not a good time. If cellulitis becomes kind of so bad, potentially scraping away of the layers of the epidermis, dermis, potentially down to the hypodermis, if it is that deep, will be necessary. This is called surgical debridement. And that is not a fun time, if you can imagine. So here we've got some images of cellulitis, that swelling, that redness, tenderness. In that top right picture, we can see that the skin is kind of almost ruffling down. It also looks a little kind of on the damp side, and that is because this swelling is causing the interstitial tissues, the intracellular tissues, to become squished out of the body. So through your cells, through your skin, you are losing lymph or fluid, which that's also not a good time, guys. That leads us to staphylococcal scalded skin syndrome, or SSSS. The microbe type is going to be a bacteria. The causative agent is the bacteria Staphylococcus aureus. Now, you're going to recognize this guy as being one of our home team. This is when he kind of turns evil, if you will. This is going to be the second dermolytic disease that we're going to talk about. The reservoir is humans. The transmission is direct contact as well as through carriers, typically caregivers, that pass the bacteria to another person, usually babies or newborns, because again, their immune system is trash. They don't have time to develop immune systems after being born, so they cannot fight off these infections at all. There are three main signs and symptoms I want you to know and understand when it comes to staphylococcal scalded skin syndrome. The first is that an exotoxin is produced, and that toxin can enter the blood through some type of infection, possibly from impetigo, and that leads to this SSSS. And then from there, once in the blood, that toxin travels throughout the body. These toxins can cause a bulla, those large fluid-filled lesions, those boils, and this is going to start to cause the layers of the skin to separate. That's horrifying, guys. That is a terrifying symptom to look for as well as just to experience. This is where the epidermal tissue layers will start to split apart. This is not what we want at all. Obviously, our skin layers, so the epidermis and the dermis, should be staying together. However, these bullas or boluses need to or will start to form between the layers of the skin, where that top layer that is being pushed up and off will start to kind of fold like an area rug that is being bunched up. Now, because of this, and because those skin layers start to bunch up and fall off because they're dying, because they don't have blood flow to them, this is going to leave this individual with the appearance of burns. So that is actually kind of how we treat it as well. We treat staphylococcal scalded skin syndrome as if this person had a severe burn. So antibiotics, pain meds, IV fluids, and ointments. So typically this individual is going to be in the ICU or a burn unit because layers of their skin are missing. So they are very susceptible to other infections at this point in time. The prevention for this is good hygiene and keeping wounds clean. So some very unfortunate pictures of this condition. You can see a lot of it is going to be in the armpit region or axillary region. That is because that area is going to rub and fold and stretch. So that is where we see a lot of issues. So again, the appearance is like scalded skin. So the name itself is actually telling us a lot of information, that it is staphylococcal bacteria, and it causes this scalded skin appearance. So that is what it looks like. Okay, that leads us into vesicular or pustular rash diseases. So these are going to be lesions that have fluid inside of them. The first disease we're going to talk about is chickenpox. Chickenpox is going to be the microbe type virus. This is another human herpes virus, also known as varicella virus. So if you know it by varicella versus chickenpox, you can remember it as varicella. If you want to remember it as chickenpox, go for it. Either one will be on the exam. So remember either one will help you. The reservoir is humans. The transmission is respiratory droplets, or, and it's really kind of gross, if you pop a pox. So the pox is the lesion itself. The pox is filled with a fluid that is filled with the virus. So that fluid is chock full of those viral particles, right? So if you come into contact with those viral particles from the popped pox, then that can also be a mode of transmission. Super gross, super cute. We love it. The incubation period for chickenpox is actually pretty long as well, and you are contagious during that time as well. So keep that in mind. Another reason why chickenpox is so contagious. Okay, so as I said before, chickenpox is super contagious. We have this fever, rash, skin lesions, starting as macules, turn into papules. They become really itchy because these papules are sitting on top of nerve endings. So they're not in the nerve ending yet. We'll talk about that when we talk about shingles. But what happens is the pox is going to sit over the top of a nerve ending, which is going to make you feel like you have to scratch it because you're going to be real itchy. And that is kind of the point. The point of the virus itself is to want to make you to scratch those poxes, break them open, and spread the virus. But if you don't scratch, and kind of think about kids with those mittens duct taped on is what I think of. You don't scratch them. They don't bust open, and they'll dry up and drop off. Now, if you scratch them, break them open, it could lead to scarring, but it'll definitely lead to that infection spreading. Now, the number of pox per person has a tendency to change. Initially, we thought it was related to genetics. However, we are realizing that it does not relate to genetics. It's just kind of the luck of the draw. You get a few pox and it then goes away. Fabulous. Good for you. Some people, you're covered with it entirely. So it's just entirely per person is their own individual experience with chickenpox. However, we do see with the pox themselves, they primarily stick to the head and trunk, with very few lesions leading to the outside of the body, the extremities. The prevention is going to be the varicella vaccine, or sometimes now it is clumped together with the MMR called the MMRV vaccine. So measles, mumps, rubella, and varicella vaccine. So you can squish it all together. I don't know what's better per se off the top of my head. However, kind of seems nice to get all 4 of those vaccines all in one. Kind of a one and done, but I'm sure there's boosters as well. But either way, those are our prevention methods. Treatment is, well, guys, it's a virus. It's got to run its course. There's not a whole lot of things you can do other than try to encourage either your kids or yourself not to scratch. There are antihistamine lotions that can help cut your kids' nails so that they can't spread that virus when they're scratching. But yeah, that's kind of all the treatment we can do. Now, I want to preface here that chickenpox is kind of known as being a virus, a disease that runs in kids. However, you can contract chickenpox as an adult. The first time you get this virus, it is chickenpox. The second time it pops up, because HHV3, that virus, is a creeper virus. The next time it pops up, it's called shingles. Now, because this virus is known as a creeper virus, it can go dormant for some period of time, usually years upon years. And then potentially at some point in time when the immune system is kind of taking a hit, shingles can pop up. Shingles is that second round, and it can also be more than 2. So that is the next round of essentially chickenpox, but it's not the same thing. Chickenpox is uncomfortable because you're very itchy, but it is typically not painful. Shingles is very painful. So there is also another defining feature of shingles in that it has an asymmetrical distribution on either the head or the trunk of the body. And I have a picture here in a little bit that shows the difference between chickenpox and shingles. However, again, I want to reiterate, it's the same virus, it's just popping up for another time. So chickenpox is the initial infection. Shingles is when chickenpox goes dormant and pops up again, usually later in life. The prevention of shingles is going to be this vaccine, Shingrix, I guess is how you say it, and it is particularly effective. So this is different than the chickenpox vaccine, so a little bit different. May want to get it if you had chickenpox. You may want to get the shingles vaccine to prevent this experience from happening, because you're gonna be happy you did. The only way to really treat shingles is lotions and creams, nerve blockers for the pain, because again, it can be really, really painful. The reason being is that while chickenpox sits on the end of a nerve, encouraging you to scratch, shingles is actively inside of the nerve, because when chickenpox goes away, it just kind of rides along the nerve that it was on and goes into your spinal cord to lie dormant for a while. Then when shingles pops up, it rides one of those nerves, and that's why we have that asymmetrical appearance. It's just on a nerve. And rides its way out, so across your head or across the trunk of your body. So let's look at a picture of that. So we've got chickenpox on the left, and that is covering the trunk of this young individual's torso. And then we have shingles, where we can see that it's all in almost this like perfect line going across this individual's torso, but not covering their torso. So this is riding that nerve essentially across this person's torso. Kind of weird, kind of crazy. Again, chickenpox is going to be uncomfortable because you're itchy, but not painful. Shingles, very painful. And it is that second popping up, that waking up of that same virus that causes chickenpox. All right, that leads us to hand, foot, and mouth. This is going to be a viral disease, so that is our microbe type. The causative agent is a handful of enteroviruses. However, that's all I want you to know for the causative agent, is that they are enteroviruses. The reservoir is humans. The transmission is respiratory droplets, direct contact with contaminated mucus, saliva or feces, or indirect contact with fomites that might have those products on them. There are a handful of signs and symptoms, but there are two that are particularly interesting and unique. The first is painful blisters in the mouth. That is a very unique symptom and sign, actually, as well as rashes on the hands and feet, sometimes the buttocks. I know that's spelled incorrectly. Don't judge me here. With those rashes, what I need you to understand is it's very odd that this rash shows up on the palm of your hand or on the bottom of your feet. Now, it can lead to complications like encephalitis or meningitis. That is not a good thing. Those are very scary complications. Don't know if they're particularly common, though. I believe they can be pretty rare. The prevention is good hygiene, and the treatment is, well, there is no real treatment, just managing the symptoms. So here we have hand, foot, and mouth, what it looks like. So that rash on the hands and feet, sometimes around the mouth, and we can see on this child's mouth that a little bit of a pustule is potentially starting to form there, but usually they are a generally kind of flat rash, but they could contain pus. The last disease we're going to talk about for this first part of skin diseases is going to be smallpox. So smallpox is going to be a virus caused by the variola virus. And what's really unique about this particular virus, this disease, is that it was found in humans and now it's not. Now, where did it go? Well, we've eradicated it. There's no naturally occurring outbreaks of smallpox since 1949. There have been a handful of cases, but usually it's caused from, I don't know, people doing research on smallpox and then they accidentally infect themselves. But then they're very closely watched and treated, and that does not spread. So the transmission is usually through indirect contact. You'll see why here in a minute. Has a lot to do with how contagious those scabs and the fluid inside of the pox is, and also respiratory droplets. So the signs and symptoms. Now, we do have quite a few, high fever, rash on the tongue and in the mouth, but the thing that we need to make note of is that rash inside of the mouth is usually some type of boil that will burst, and that boil is full of the virus itself. It will then spread that virus to the rest of the body within 24 hours. And then we start to see pustule lesions that cover the body, and if given enough time, they'll crust over and eventually fall off within about a month or 2 months. However, in that month to 2 months, the crust, the scabbing, and the fluid within the pustules, the pus in the pustules, my apologies, is full of the virus. So fomites, like bedding, sheets, blankets, clothing, if you're sitting on a chair, a table, play equipment, whatever, you are spreading smallpox everywhere. That is why it is so highly contagious. So for prevention and treatment, we have a vaccine. It was very effective. Hence, we eradicated smallpox, but there is no true treatment once you have gotten smallpox. This is why the vaccine was so important. So individuals who had smallpox, very severe cases, this is what it looked like. Not a good time. The two boys that you see there in the black and white picture were part of a campaign for the vaccine. So the boy on the right got the vaccine, the boy on the left did not. He got the placebo. And this was a really big push to get people to get the vaccine because while, yes, this looks horrifying, potentially smallpox is not precisely what killed you. It was the secondary infections is what killed you. I mean, that doesn't look comfortable in the slightest. It looks atrocious. Not to mention, you are going to have scarring for the rest of your life. But it's those secondary infections that smallpox would lead to that would lead to that massive amount of death. So anyway, that is the end of the first part of chapter 16. Hope you enjoyed these fabulous diseases. We are going to continue on, and it only gets more fun from here, as fun as diseases can get. So again, I would start using that template guide. Start throwing in all of these diseases that we're talking about and that pertinent information that you need to know for each one. I think that would be the best way to study the diseases. So happy studying. If you have any questions, please let me know. I'm always available.